Hi, everyone. Thank you so much for attending our medical education workshop, Addressing Gender Bias in Medicine and Healthcare. Thank you to the Canadian Federation of Women in Medicine for supporting our curriculum. We're very excited to discuss and explore gender bias in healthcare with all of you. My name is Rebecca.
My name's Hannah.
And my name's Haley.
The medical education workshop team at Medical Herstory seeks to educate many different audiences about gender bias in medicine. In the past, we've presented to medical students, health science students, physical and occupational therapy students, and most recently, we collaborated with the Association of Anesthesiologists in the UK. Today, we are excited to be presenting to an even wider range of people, all of whom we believe can help tackle gender bias in medicine.
So to give you a broad idea of what we'll be discussing, we want to emphasize two things. The first main point we want to drive home is that gender bias persists within society and that it's everyone's responsibility to dismantle it, including healthcare providers, teachers, scientists, politicians, scholars, and many more. The second point is that a patient-centric approach to tackling gender bias is essential if we strive to understand the manifestations of gender bias and improve healthcare. Our goal today is to equip you all with the ability to identify and eliminate gender bias in your own career, learning, and personal life. Whether you are a healthcare provider seeking to improve care for your patients, a person who has received healthcare in the past, or someone who simply wants to learn more about gender bias in healthcare, we hope that this workshop will inspire you to challenge your own understanding of the factors influencing health and illness in our society. So before we delve into this, we encourage you to reflect on what you're hoping to get out of the workshop and share in the chat if you feel comfortable. I'll just give a minute, but no worries if not, there's plenty of chance to participate later on. So today's workshop is divided into 3 parts. First, we'll be going over some background information and defining gender bias. Part 2 will address present-day gender bias in healthcare and how to identify it. And here we'll not only discuss what it looks like today, but also how it still persists, often despite best intentions. And part 2 also includes a case study activity led by Haley, which will allow us to start thinking about the possible manifestations and lived consequences of gender bias for people receiving healthcare. And lastly, part 3 will present some strategies to disrupt gender bias in healthcare and society.
Before we get started, we're just going to go over some guidelines and disclaimers. So in terms of Zoom housekeeping, please keep your mics muted unless you want to speak. If you want to raise a point or ask a question, you can raise your hand or write it in the chat. And closed captions can be turned on or off at the bottom of your screen where it says CC. We'd also like to provide a content warning. The workshop will address sexism, racism, ableism, and specific medical experiences. These topics can be heavy, so we encourage you all to take breaks, check in with yourselves, and let us know how you're feeling. We also want to offer a few disclaimers. This workshop focuses on gender bias, gender referring to socially constructed behaviors, presentations, and expressions of femininity and masculinity, but we will also discuss sex differences referring to biological, chromosomal, and genital differentiation. Medical Herstory acknowledges that gender and sex can often become conflated, and we do our best to create a space that is trans and non-binary inclusive. In our workshop today, we will be using the term women as a shorthand to include people who identify as, have ever identified as, or been identified as women. For specific disorders, we encourage the use of gender-neutral terms like menstruators or people with vaginas or uteruses, because not all people who menstruate or who have certain reproductive organs identify as women, and the words we use matter. Further, while this workshop focuses on the patient perspective, we want to acknowledge that most people are patients at some point or in some capacity, and therefore may have their own insight into gender bias. Today we will be centering lived experience, and we encourage you all to reflect on and speak from personal experience throughout this workshop. Finally, we want to emphasize that what's said here stays here and what's learned here leaves here. This is a safe and non-judgmental space to ask questions, and the goal is really to learn together.
Great, so this brings us to part 1, defining gender bias. The formal definition of gender bias can be understood as having 3 facets. First, the systemic neglect of certain genders, whether that be women, non-binary people, gender fluid people, or men, and this is often unintentional. Second, stereotyped assumptions about people's health, experiences, needs, and behavior based on their gender. And third, neglect of gender-specific issues that are relevant to the topic at hand. The general discussion usually centres cisgender women's experiences, as does a lot of today's workshop, but gender bias negatively affects all people, whether they be cis, trans, non-binary, intersex, or gender fluid. Further, it's important to keep in mind that gender-based disparities are exacerbated for low-income, racialized, and disabled people.
It's now time for some trivia that will explore the history of gender bias in healthcare. So you can give us answers and guesses in the chat. So the first question, historically acting unladylike, having a high sex drive or disinterest in raising children were symptoms of what medical disorder? Anxiety, depression, hysteria, or endometriosis. So just put your guesses in the chat. Okay, hysteria, depression, hysteria. Any other guesses? So the answer is hysteria, which is what most people guessed. And this question shows that diagnoses and assumptions made in the past can and still do influence present treatment. I'm sure we've all heard the expression of a woman being hysterical. In fact, hysteria was an affliction coined by Hippocrates from the Greek word for uterus, hystera. The term hysteria persisted in medical textbooks until as recently as the 20th century and encompasses, among others, conditions we now recognize as endometriosis, epilepsy, anorexia, and chronic fatigue syndrome. It was previously believed that hysteria was caused by dysfunction of the uterus and that only women could be hysterical. This link is still evident today in the term hysterectomy.
So our next question is, in 1873, physician Edward Clarke wrote an article stating that school was unsafe for women for which physiological reason? This one's a bit harder, but again, if you could just make a guess in the chat. So we've got one guess, periods. That's a really good guess. Any others? And mood swings from Ellen, another really good guess. So I think we'll move on because it's quite a hard question. But the actual answer, yeah, well done, Barbara. It's potential infertility. So the answer is that he argued women have less blood than men due to menstruation. So whoever guessed periods, you're kind of correct. And that schoolwork would move the blood away from vital reproductive organs, making them infertile. And although this might seem quite comical today, it does speak to the persistent idea that menstruation might leave women unfit for certain occupations or positions.
Okay. Our next question is, what year were women required to be included in clinical trial research studies in Canada? So you can just put any guesses in the chat. Let's see, 1990 is the first guess. Any other guesses? Do you think it's earlier, later, 1980, 1970, 2005, 2000, 1970s? Okay, luckily it's not as bad as 2010, but the answer is only 1997. And that is when Canada adopted a guideline that recommended that women should be included in all phases of clinical trials and in an adequate sample size. In the US, the requirement to include women in federally funded trials has only existed since 1993. And in the UK, there's actually still no clear reference to considering gender in research design and analysis among many of the main funders of clinical trials. Okay, question 4. The Baltimore Longitudinal Study of Aging, America's longest running study of aging in humans, failed to include women for how many years after it began in 1958? 2 years, 5 years, 10 years, or 20 years? So again, if you could just put your guesses in the chat. Let's see, 20, 20, 20. Okay, the answer is 20. And this failure is significant as women live longer than men on average and also spend more years on average in ill health and disability. Therefore, it's important for the healthcare sector to understand the process of aging in both sexes.
And now this is our last question. Of all the drugs taken off the US market between 1997 and 2001, what proportion of these were removed due to increased risk for women? So we've got A, 30%, B, 50%, C, 80%, and D, 100%. Got 30, 30, 30, 50, 50, another 30. Any other guesses? So far we're split between 30 and 50, it looks like. The answer is actually 80%. So 8 out of the 10 drugs that were taken off the market in this period were due to increased risk for women. Although this is from a while ago, this statistic sheds light on the fact that biomedical research is largely androcentric, which means it favours men and commonly ignores other genders. There are several reasons for this, including the ethical dilemma of testing drugs on people who could become pregnant during the clinical trial. And there's also the idea that the male body is a more neutral environment, supposedly, with female bodies being seen as too hormonally volatile and thus perhaps interfering with the intended pharmacological effect. So great job on the trivia questions, everyone, and thank you so much for participating. As these examples show us, gender bias runs deep in the history of medicine. It has shaped healthcare and the health sciences in various ways, but these problems are not only things of the past.
So that brings us to part 2 of the workshop, Identifying Gender Bias. In this section, we're going to introduce you, can we go to the next slide?
Oh, sorry.
In this section, we're going to introduce you to 3 key concepts: the trust gap, the research gap, and Yentl syndrome. If you were here for Tori's talk earlier or another one of our previous workshops, you may recognize these concepts. So the trust gap refers to the fact that women's self-reports about pain and illness are more likely to be disbelieved and dismissed. Historically and currently, women, and especially women of color, have been stereotyped as hysterical, overly emotional, untrustworthy, or unreliable within medical settings. Women's pain is more likely to be dismissed as psychological rather than physical, and widespread ailments that don't affect cisgender men are under-researched and poorly understood. Further, they're often normalized as an inevitable part of being a woman. For instance, endometriosis is a condition that affects at least 1 out of 10 people with vaginas. This condition is often dismissed as normal menstrual pain, which contributes to an average diagnosis time of 8 years. Now, if anyone is still thinking that these discrepancies have nothing to do with gender inequity, but a lack of resources and overworked medical systems, we're not saying that those aren't factors at play, because they are. What we're saying is that this lack of resources is going to disproportionately affect women due to gender bias. Further, it's important to highlight that the trust gap persists regardless of the gender of the practitioner. Gender bias is made up of systemic inequities and implicit biases that involve all of us, which is why we must all do our part to dismantle these systems.
So next, we want to address the research gap in medicine. Biomedical research efforts often ignore gender and sex differences, for example, in drug trials and development, and in defining certain disorders markers. This stems from the historical exclusion of women from clinical trials for decades. Sex bias in clinical trial enrollment still persists, as shown by a cross-sectional study examining trials from 2000 to 2020. Women were underrepresented in various medical fields, including neurology, immunology, hematology, and many others. In addition, there is limited gender disaggregated data by disease, leaving little information of gender differences in these diseases, and it results in women living unhealthier lives. Just to give you an idea of what this looks like concretely, about 70% of people with chronic pain are women, yet 80% of pain studies are conducted on either men or male mice. This research gap directly influences patient experience and care. To illustrate this, we'd like to introduce you to the term Yentl syndrome, which comes from the movie Yentl, where the woman protagonist poses as a man in order to get the education she wants. In medicine, Yentl syndrome refers to the idea that unless their symptoms resemble those presented by men, women suffering from the same condition will be underdiagnosed and undertreated. For example, women are 7 times more likely than men to be misdiagnosed and discharged in the middle of having a heart attack. This is because heart attack symptoms differ according to sex, and many medical students have been trained to respond to patients who present as a 70-kilo, able-bodied white cis male. In health, innovation, and clinical research, there is still a lack of female representation, especially in mammalian research. Because a lot of our understanding of biology is derived from studies on animals, this exacerbates the gender bias. So, as Tori explained earlier, we can see that women basically face a double bind within healthcare. On the one hand, they know that their story might not be trusted, yet on the other hand, even when they are believed, healthcare providers might have limited treatment options due to the limited research and medical teaching on women's health. At the end of the day, when conditions are researched, defined, and taught according to how they present in male bodies, everyone's care is compromised.
One glaring question is, why does gender bias persist in medicine and science? Answering that would require us to have broader conversations about patriarchy, sexism, racism, and other structures of oppression. One question we can begin answering, though, is how does gender bias persist? And our answer is that gender bias exists on multiple levels. On a societal level, gender norms that it is unladylike or inappropriate for women to discuss their bodies, their pain, or their medical mistreatment lead to shame, silence, and additional barriers to accessing care. On an interpersonal level, these societal biases become internalized by physicians, often unconsciously, and this leads to implicit bias in the medical care women receive. On a structural level, medical care has a long history of abusing women, especially Black, Indigenous, and disabled women, and these inequities are built into the systems that presently offer care. And lastly, on a research level, women's health is underfunded and under-researched across academic disciplines. On the structural and societal level, gender bias is spread through medical education and even sex education. This happens through supposedly neutral channels. For example, Emily Martin's The Sperm and the Egg article argues how textbook descriptions of the sperm fertilizing the egg reflect stereotypical gender roles. The egg is passive and gentle, and the sperm is brave, aggressive, and the one that accomplishes fertilization. But the characters it attributes, the passive egg and the active sperm, do not reflect the process accurately. These principles perpetuating gender bias are taught from a secondary school level and are still prevalent in medical school curricula today. We know now that the egg plays a very active role in choosing and capturing the sperm. Science is not objective and is furthermore not immune to bias, sexism, racism, ableism, etc.
On a research level, to this day, feminist health research is persistently underfunded, and there appears to be gender bias in the scientific process, from funding to the way that the science is conducted. In July 2021, an analysis of funding provided by the US National Institutes of Health, or NIH, concluded that in cases where the disease favors one gender, there is overfunding of diseases affecting men and underfunding of diseases affecting women. As well as this, analysis of the grant awarding process of the Canadian Institute of Health Research found that grant reviewers potentially expressed gender bias. The success rate of grant applications based on the merit of the applicant was significantly higher in male applicants. However, success rates in application programs which judged scientific approach as opposed to merit had no such gender difference. As you can see from the infographic on the screen, about 1% of biopharma and 2% of medical technology investments are allocated to non-cancer conditions associated with women or people assigned female at birth. These conditions are further broken down into the various subcategories on the right, so contraception, fertility, maternal health, menopause, gynecology, and gynecological infections. If we look closer at menopause, we see a very interesting disproportionate allocation of research and innovation. About 50% of the population have reproductive organs such as a uterus or a vagina and will experience menopause that on average lasts about 4 to 10 years. About 70% of people experiencing menopause will have symptoms, yet less than 5% of femtech innovation is geared towards menopause. Let's look at another example, artificial intelligence. Artificial intelligence, or AI, has been hailed as one of the next big innovations in healthcare technology, with potential uses including diagnosis and treatment. However, with female participation lacking in many clinical trials and scientific studies, our medical knowledge is heavily biased towards male bodies. Data sets that these AI algorithms are trained on are often heavily skewed towards male images and voices. The most popular database used to train speech recognition technology consists of 69% male voices. And in 2017, men greatly outnumbered women in two commonly used algorithm training image datasets, which contained more than 100,000 images between them. Authors of one image labeling study said that structured prediction models amplify bias, which means that unless an active effort is made to equally represent all genders in datasets used to train algorithms, AI could potentially be ineffective or even worsen diagnoses for women. This is despite many conditions affecting women and their quality of life already taking a disproportionately long time to diagnose, as we saw earlier in our endometriosis example.
We'll now pass the mic to Haley for our case study activity, which should help you think about the patient's perspective and how they experience gender bias.
Hi, everyone. And so we'll move on to our case study. Today, we'll be discussing a real patient story submitted to our website that describes the lived experiences of receiving care for lichen sclerosis, as we actually already discussed earlier today. So just to remind you, it's a chronic inflammatory condition affecting the vulva. So the story is quite interesting because the author describes their experiences as both a patient living with lichen sclerosis, as well as a healthcare student confronted with the gaps in medical education. So in the interest of time, we have selected a few key paragraphs for our discussion today, but we encourage you all to head to our website to read the full story and other patient perspective stories. And so I'll read this out for you all today. And so as you can see on the slide, this is our story. And so I will read, I've returned twice a year for the next 2 years. Making the appointments was easier than even seeing my GP. I called the sexual health center, asked for the doctor by name, and we'd be booked in that week. I left every time with my brown bag of medicines until one day when I called to ask for the same doctor and was told that she's retired and there was another gynecologist and that I really need to see her. I booked an appointment. A local newspaper article celebrated the first doctor's retirement and she beamed from her manicured garden. This was destined to be an uncomfortable appointment because I'd not been using my clobestrol as much. It was frustrating to apply ointment that came off whenever I used the bathroom and it would tear the skin if I applied it too cold. The new doctor examined me and told me things weren't looking as good as they should, and I confessed. She launched into an explanation of why the clobestrol was important to preserve my vulval architecture. She drew diagrams, she gave me leaflets. I was a student nurse and I knew her job in that moment was to explore why I wasn't taking it. I sat quietly and waited for my brown bag. No, she said, you have to get that from the GP. I told her sex had become unbearably painful. She handed me a tube of lidocaine and told me to apply it to my vulva so that I could be numb and tolerate sex. I left the consulting room in silence, limpidly gripping the lidocaine. I couldn't fathom the concept of being numb to tolerate sex. Shadowing in a gynecology clinic recently, I heard a junior doctor or resident tell a patient that she might have lichen sclerosis because it is a condition of postmenopausal women. Once the patient had left, I told him that wasn't strictly accurate. The consultant, equivalent to an attending in the States, said it mainly affects pre-pubertal and postmenopausal women. I told her, I know that it doesn't only affect those age groups though, because I have it. I was diagnosed at 24, but that's the only reason I know. Lichen sclerosis is a core condition on our curriculum, but we've had no teaching on it. The doctor explained the competing interests of academic curricula versus clinical workload, but the consultant shut him off. This is why so few good students are attracted to gynecology. They aren't taught from the start. And so we'll move on to our discussion questions. I'll post the questions in the chat for all of you. So the first point that I would love to discuss is the patient's health issue. And so can someone tell me kind of what had been going on in this study or this story, sorry, and what the issue was that was discussed? And it's okay, you guys don't have to be shy. You can post in the chat or you can unmute yourself. We're happy to hear any of your voices. And yes, lichen sclerosis. And I think too, we need to also address the fact that the issue here was not only just a medical issue, but the lack of services and treatment and continuity of care, I think, as well, if anyone else has any ideas. And we can move on to the next question. And so, yeah, oh, actually, there's a chat here. So the patient was forced to see a different doctor from the one she requested. And as we mentioned, yeah, medical dismissal, not addressing the patient's concerns. Vulval vaginal health is highly stigmatized. So you can imagine that, you know, having continuity care with one physician is very important, and then having to switch might not be so comfortable. And lack of knowledge and awareness of lichen sclerosis, for sure. So the next question is, what was the healthcare professional's assumption or assumptions? So let's deconstruct that. How do you think gender bias led to this assumption as well? Yeah, that it only affected certain populations. That's a good one. And quite interestingly, this goes hand in hand with the conversation that was had earlier today, how lichen sclerosis does not only affect one age category. So that's really important to know when you're, you know, addressing healthcare needs for people of all different ages. Oh yes, and here's the story here, in case you guys would like to refer back to it. Also, does anyone want to speak to, oh, here, also the doctor assumed that tolerating sex was a favorable patient outcome. Yes. It doesn't really give you much encouragement when that's what was the last thing said to you. The physician's dismissal of the patient's painful sex. The assumption that sex for a woman is, pain probably for sex is normal and therefore does not warrant further investigation. This caused misdiagnosis and patient harm. Yes, thanks, Victoria. The patient was forced to have the cabedestal to the doctor didn't explore alternative treatment options, which is their duty as a doctor. And hand in hand with that, as well as that she didn't explore as to why she might not be taking the medication. It was more so that she assumed that the patient didn't know the importance of taking the medication, when in reality, it's the patient experience that was dismissed. Gender bias contributed to this assumption because historically women's sexual pleasure has been devalued and deemed unimportant, both in society and medicine. That's a really good point. Very unfortunate, but good point. And so we can move on to the next question. And so how about let's discuss how you think that this patient felt in this experience. Unimportant, invalidated, and gaslit, dismissed, dehumanized, overlooked, frustrated, again, frustrated, dismissed, annoyed. Confused, that's a good one too. Let down. Altogether saying not a very empowering medical appointment. Her concerns not being taken seriously, powerless, repressed. Yeah. Okay, let's go to the next question too. Those are really good points, everyone. What were some potentially dangerous consequences resulting from the professional's biased interpretation? Non-compliance with treatment, the patient not returning. Patient not seeking additional help. Not considering lichen sclerosis as a diagnosis in premenopausal women, leading to misdiagnosis, yes. Those are all really good points. So it just goes to say that this can be an inhibitor for future care and empowered care for this specific patient. But also imagine to all the other patients that might be presenting to these clinics who also have lichen sclerosis and what their experiences is. So it's not just this one experience, unfortunately, that is probably impacted by this physician or by these biases. And so last but not least, we have the last question here is what the professional should have done differently to center the patient's problem and their complaint. So essentially, what could have been done differently? Simply asking for her ideas, concerns, and expectations. Ask more about why the medication wasn't being used as was advised. Look into her complaints more. The physician should have recognized the potential for gender bias and instead held space for the patient to share her story and concerns. Patient-centered approach, ideas, concerns, and expectations. Investigated the cause of painful sex. Yeah. The physician shouldn't have given an excuse about competing interests. Accountability. And so I am a fourth-year medical student, and we learn this wonderful acronym called FIFE, which is your feelings, ideas, function, and expectations. And in doing so, opens up this ability for the patient to share their story. But it's funny because you'll learn this in medical school, and then when you go into practice in clinic, you don't see physicians using this scope of practice and allowing the patient to tell their story. So I think it's really important for us to keep reminding each other, no matter what capacity, that we need to do this, and it needs to be an active involvement with the patient. Yeah, so we use ICE. Okay, yeah, there's different ones. I love this. It's called FIFE. I'll put it into the chat. And it's important. We are mandatory to use FIFE in order to pass our oral examinations, but it's one thing to learn it or do it in that setting, and then another to do it in real life. So I thought that was really important. And also someone mentioned this morning, I'll just say this again, because I think it's important for our last question, was to always be curious. And so not being afraid to ask people about whether it be their gender identity, about whether their lived experiences, but always be curious, which allows that patient to feel like whatever their experience is not only important, but also valued in that clinical setting. So yeah, be curious, non-judgmental. I love that. Okay, well, that wraps up the last minute questions. And so thank you all for engaging with this story and also for putting your answers into the chat. And don't forget, you can find similar stories like this on our website if you want to read different patient perspectives. And I'll give it back to the other two.
So thank you so much, Hayley. I'm also a medical student in the UK. I think that's why people are using ideas, concerns and expectations, which is ICE, which is what we learn. So I guess that's your equivalent. But yeah, we're now at our last part, which is all about strategies to disrupt gender bias, but these are also useful to address other biases as well, such as those relating to race, size and disability. And if you want to continue having a conversation in the chat, please go ahead. Yeah, that's what we like. So first, we want to ask if you have any ideas about how you can disrupt bias before we go through ours. And this could just be ones that you've seen in your day-to-day lives. If you've been to the doctor before, any ideas you have there, or anything that you've reflected on from the story we just went through. And feel free to unmute yourself or just write it in the chat. It's okay if not, we'll move on. Oh, we've got an answer. Thank you, Helen. So we've got doctors doing further research instead of just sticking to very old textbook material, which can be out of date. And yeah, definitely for sure, like keeping updated with the most recent advances in material is really important. Taking a person-centered, holistic approach and seeing the person as a whole rather than their gender, absolutely. Like in the lichen sclerosis story, if the doctor had maybe just taken a moment to explore the effect of a presenting complaint on the patient's life, it might have made a difference. And pursuing ongoing education, not just medical science, but also combining humanistic perspectives as well. Thank you so much, Victoria, and probably apply that to myself as well. So please continue to write in the chat, but we'll just go through some of our own strategies to combat gender bias on different levels. So these include on an interpersonal level. So one barrier to the implementation of policy regarding gender bias is insufficient awareness. So we can combat this by speaking up when you witness sexism or gender bias. And just before I move on, we've got another answer in the chat, which is to reflect on diversity of people surrounding you and your internalized biases. So that's one of the interpersonal strategies that you can use, and reflect on the background of the resources by which you've acquired your knowledge. So thank you so much. We'll move on to that also in the structural section. But before that, on a societal level, remaining aware of potential biases in institutional publications you're exposed to, whether that be journals, textbooks, as we mentioned, or other sources of authority. And one way of doing this is by paying attention to the participant demographics in randomized control trials to understand what kind of population these results were studied in. And you can also join existing associations and clubs at your university or in your community. On a structural level, we can push for curriculum changes where possible to be more inclusive. And on the part of policymakers, we can take the opinions of advocacy groups into consideration when formulating policies, as they likely have really valuable lived experience. And we can also understand better the barriers to implementation and the potential weaknesses of policies. And finally, on a research level, we can emphasise sex and gender-based analysis, which is a policy developed by Health Canada, which encourages the inclusion of sex and gender into research design. And there are also training courses available to learn about gender-based analysis. And another barrier is the lack of funding and resources. So one way that we at Medical Herstory combat this is by creating a space for feminist health research at our annual Feminist Health Research Conference. And I think tomorrow there'll be some student researchers presenting that. And we've also held fundraisers in the past. You can also support other feminist health research and research conferences. So for example, the NIH's Office of Research on Women's Health has a list of conferences and workshops that promote emerging scientific concepts and technologies centered around women's health and sex differences.
As well as the institutional and interpersonal level strategies discussed above, we propose the following strategies to address gender bias in the clinical setting for those of you who are planning on becoming healthcare providers. These include setting up a trauma-informed space, including speaking to patients with open body language, not blocking exits, always asking patients for consent to touch them, and explaining what is being done and why throughout the appointment. This bolsters patient autonomy by better understanding what's going on and also gives patients a chance to voice their objections or reservations. Being inclusive, including always asking for a patient's pronouns, preferred name, and never assuming gender identity or sexual orientation. And fostering collaborative and patient-centered care by including patients in the treatment plan, encouraging questions, believing their pain, and not dismissing their concerns or suggestions. It is so important that healthcare practitioners trust that patients are the experts of their own body and life. You may know a lot about human biology and treatment, but only they know what it's like to live in their body.
So lastly, tackling your own gender bias will undoubtedly involve a lot of self-awareness and self-reflection. And for that reason, we suggest striving for humility by acknowledging that all people, including everyone here, entertain certain biases, stereotypes, and assumptions, no matter our identity or how well-intentioned we may be. We all have a list of things to do or think about to eliminate gender bias in our professional and personal interactions. And these are in your conference handbook, so don't worry about memorizing anything. So first, you should remain aware that you might be operating according to certain biases. This self-awareness should allow you to identify how gender bias might have played into your interaction so far. Second, once you've identified it, try correcting your approach if immediately possible. This can involve checking in with yourself that you haven't missed any important information, or checking in with your colleagues or peers to make sure you accurately understand their point of view. And lastly, it's important to reflect on interactions afterwards. You could even keep a reflective journey to unpack when you find yourself passing judgment or making gender-based assumptions about others, and reflect on where those feelings came from and what you can do differently. The better you understand how gender bias affected your approach, the more that you'll be able to adjust it next time. So now that we've gone through all these strategies, we'd really love to turn it over to you and hear what you're planning on doing differently to disrupt gender bias in your own career. So perhaps this could be something we didn't mention, or maybe something that we said that has struck a chord. Again, please unmute yourself or write it in the chat, or if you'd like to send it to me or Hayley or Rebecca to read out if you're not comfortable putting it in the chat to everyone. So anything that people might have reflected on from the story? Yep, using gender inclusive language, absolutely. And from someone who's involved in clinical neurology research, advancing gender equity looks like reevaluating the statistical models behind cognitive assessments and other measures. Absolutely, I think when we were writing the script for this workshop, that was something that surprised me with the AI stuff. I thought it would help be more, I thought that the AI stuff would help sort of be more objective in diagnoses, but often now I've learned that it could actually exacerbate it and make it worse. Using feminist methods in all research, and yeah, algorithms are absolutely really dangerous in research if not sort of thoroughly created with all biases looked at and addressed. And yeah, I feel like we sort of skipped over Tori's point, sorry. So using feminist methods in all research, so whether that be sort of looking at other feminist health studies and sort of applying those methods to your own to make sure that we try and minimize and eliminate gender bias in our own practice. Thank you everyone so much for sharing those. And if you want to continue writing in the chat, feel free.
Yeah, and
oh, sorry.
We have someone else that said, I work in public health as an RN at a sexual and reproductive health. I will definitely work on journaling more and after each client visit, also enforcing my feminist education and incorporating that into clinical care. That's wonderful. Something I've realized too is that I'll learn a few facts, like for example, even that women are dismissed 7 times more likely with an active heart attack than men. And I just share these stats with people, and I share these stats with my fellow medical students and physicians. And it's interesting because the moment you tell these people, their eyes light up and they say to me, I had no idea. And so I think just continuing on the conversation in whatever practice or whatever field or clinical settings you end up being in, I think it's important to keep the conversation going and engaging with people about it, because a lot of people just don't know that there is a gender bias in medicine. But that's my experience. We have Madeline, who says, I'm a medical student and women's health writer. Oh, that's wonderful. So I'm excited to continue writing articles on highlighting women's health issues and disseminating them amongst my peers. I think that's a beautiful thing to do. Sharing information is just, it can only snowball, right? So that's wonderful, Madeline. And Devin says, would be interesting to do a research project evaluating medical charts to see the words typically used to describe females versus males, or women of color versus white women. That is wonderful too. I know that I'm not sure what it looks like in the UK or the United States, but I have a few colleagues who have been advocating for medical textbooks to include different races and different body types as well, because we are given the very cis, typically male body if you open up an anatomy textbook, and so it shifts our perspective. And so I think doing research would also really help with that, and just seeing how we interpret that into medical language. We see a lot of derogatory language used for Black patients versus white patients. Curious to know if there is the magnitude of similar gender bias. That would be interesting. I can only give anecdotal information, but if you come into the emerge and you're a female in pain, you're probably more likely to be dismissed. And I say that because I've seen, that's anecdotally, but of course, it'd be really interesting, I think, to do the research on that and to see how different it would be with the genders and even language as well. So that's a wonderful point, Devin.
Yeah, and like on the point of like racial biases as well, like I know for kidney function tests, there's different thresholds for diagnosing reduced kidney function in Afro-Caribbeans and like white Caucasian people, and that leads to a lot of darker skinned people not actually being diagnosed with reduced kidney function when they actually are showing reduced kidney function, just because the textbook thresholds are different. So I wonder if, like, you know, when women's and men's threshold differences differ as well, if there's anything behind that. Oh, it's just been changed. Oh, that's good. Well, I mean that my medical education is out of date, because that's what I've been taught. So that's, I don't know if that's better or worse. But yeah, just goes to show.
More medical diagram posters, etc., not showing anatomy of white males. Yes, so that's actually what they have been advocating for, and so I'm hopefully in the next, little while we start to actually see that. I know that there are certain, I would say, social media platforms with sexual health that have been really good with that. But if you open up, a Bates or a Grey's Anatomy textbook, you won't see that at this time. So I think it would be wonderful. I don't know who we can contact to keep that going, but I'm sure we can join an organization. I don't know any on the top of my head. I'm not sure if anyone else does, but. Any other further comments or things that you didn't know prior to this workshop, or something else that you would like to mention? And it can be anything and everything. So just last final comments or thoughts. Well, thank you everyone for, thank you, Madeline. We got another comment. Refusing to use outdated female anatomical terms that were named by male physicians who carried out horrendously unethical studies on women. Just like the SINS retractor. I don't know if you guys know that one, or like, I forget the other one. There's a lot of history, and we went through this with our workshop for the anesthesia in the UK, but all these ideas that have been perpetuated throughout the centuries about women in pain and this lack of, I guess, awareness of women in pain and childbirth. So if you want to read a wonderful book, Unwell Woman is definitely one I would recommend. Medical Herstory, as a group, we read that, and it's wonderful.
It's in the conference handbook, I think, in like our section.
Lovely. Oh, and look, we have another comment. Increasing the proportion of women in BAME keynote speakers at medical conferences. I've actually written a paper on this in case you'd like to check it out. Thank you for sharing that. I'm definitely going to read that later. I've been opening everyone's the website, so I have a lot of content to read later. Thank you, everyone. Okay, well, if there are no other comments or questions for us, we would just like to thank you all for coming and participating. You guys were a wonderful group. We hope you continue to think about what we learned here today and apply it in practice, no matter where you are, what walk of life that you are in right now. We encourage you to keep the conference handbook you're sent. You can refer back to it at any time. You can also contact Medical Herstory if you have any questions or were curious about this conference or this workshop, I should say. And we'd like you to share your story, join our team, or keep educating yourself. And if you want to do so, please visit medicalherstory.com and follow us on all of our social media.
Fantastic. Thank you so much to the workshop team for the amazing content as always. And yeah, definitely, if you're interested in these workshops or think that you know other people who might be, we do offer them as packages for medical schools, patient advocacy groups. Really, we can tailor the content to many different organizations or purposes. So definitely reach out if you'd be interested in bringing one of these workshops to your community. We have a few minutes before we jump into networking. So I think I'll let people get a little break and then we'll meet back here at, I'm in the UK, it's 7:30 for me. It is almost 2:30 if you're back home across the ocean. So whatever it is, at 1:30, we will meet back here. So thank you again to the workshops team. And I'm really looking forward to getting to chat with all of you in our networking session. So definitely don't be shy, stick around, and we'll see you soon.